Chapter 30 will discuss respiratory tract infections, neoplasms, and some of the childhood respiratory disorders. So we'll start with common respiratory infections. So these include things like the common cold, influenza, pneumonia, tuberculosis, and fungal infections of the lung. And we're going to specifically focus on the three that are highlighted, influenza, pneumonia, and tuberculosis. So starting with types of influenza viruses, there is type A. This is the most common type of influenza virus. These types can infect multiple species. So type A includes things like avian flu and other mammalian flus like swine flu. Um, these types of influenza usually cause the most severe type of diseases. And they are also the type of flu that is the most capable of antigenic changes than other flu types. So can kind of have what we call antigenic shifts. So these involve major genetic rearrangements in either antigens, and these can lead to either epidemic or even pandemic infections because all of these antigenic changes mean that there can be little immunity to these sort of now novel types of virus. So this is why, again, our influenza A tend to be kind of the most severe diseases and are those that can cause kind of widespread outbreaks because we have a population of people with really low immunity to those now kind of changed viruses. Um, these are further divided into subtypes based on some of their surface antigens. So type A, H type A influenza viruses, and N. So things like H1N1 can contain both types of antigens. So many different kind of ways that we can talk about type A influenza viruses. The type B influenza virus has less kind of ability to have those antigenic shifts than type A. There aren't as many types of type Bs. They haven't really been categorized into subtypes. Just kind of a different influenza virus than type A. So transmission and risk of influenza. Influenza is transmitted via droplet transmission. So those with influenza who are hospitalized are typically placed in droplet precautions. Young people are the most likely to become infected and also the most likely to spread the infection. But older adults are also very likely to become infected and often have much more severe influenza signs and symptoms than other populations. Another thing with transmission and uh, just kind of susceptibility to flu is that people will become infectious a day before they even start to show symptoms. So we are transmitting flu virus before we even know we're infected. And people may remain infectious for, up to a week after illness onset. So kind of a long range of ability to infect others with influenza. Rates of serious illness and death are typically highest among people aged 65 years and older. So, as with most infectious disease, older folks with lower immune system function tend to be more at risk, although we do see mortality in all age groups from influenza is really possible. So the clinical manifestations and some diagnostic tools we can use with influenza, it usually has a relatively abrupt onset with things like fever and chills, rigors, which is kind of shaking, malaise, which is kind of overall fatigue and body aches. Headache is very common. Profuse watery nasal discharge, non-productive cough, and sore throat are also very common clinical manifestations that we see with influenza virus. Viral pneumonia may occur as a complication, more commonly in older patients. And so viral influenza may turn into a more uh, serious pneumonia in some populations. Most typically, we see this in older patients, and that's part of the reason why we see increased mortality with influenza in older patients. It's because of their higher susceptibility to developing viral pneumonias. There are also some secondary complications that may occur with the viral influenza infection. So things like sinusitis, otitis media or ear infections, bronchitis. Patients may develop bacterial pneumonias because of decreased immune response, that also because they're, someone's fighting off influenza, then they become more susceptible to bacterial pneumonias. Also, if they have a significant amount of like sputum or other things kind of collecting in the lungs, it sets up a medium that makes bacterial pneumonia more likely. Um, and in young children, sometimes we see the development of something called croup, which we'll talk about when we get to childhood respiratory illnesses. We do have rapid influenza diagnostic tests, and that can give us really, again, rapid results of whether or not someone is influenza positive. And this is really important for potential treatments because one of the only treatments we really have for influenza is antivirals, specifically something called Tamiflu. And Tamiflu, while it can't completely eradicate the flu virus, it can potentially shorten the duration of the flu and reduce its severity. But it does need to be started really early in the disease. Within 2 days of the disease developing, we need to get Tamiflu started. If we don't initiate it that quickly, it really has very little effect on shortening the duration or reducing severity. So that 2 day or 48-hour window is really important, as is rapid diagnostics. And we also want to be very careful in remembering that influenza is a viral infection. And so people with signs and symptoms of influenza and who test positive by rapid testing should not be given antibiotics. Those are not going to be effective against a viral infection, and giving inappropriate antibiotics can increase the incidence of antibiotic resistance. And so again, we really do want to avoid that when someone is influenza positive. The best treatment that we have for influenza is really entirely prevention. And this prevention takes the form of vaccines, because this is such a highly contagious virus without very good treatment options. So all people aged 6 months and older in the United States are recommended to receive an annual influenza vaccine. The formulation of the vaccines must be changed every year, and they are changed in response to antigenic changes in the influenza virus. A higher dose of inactivated influenza vaccine is sometimes given to seniors older than age 65, because a higher dose can help to stimulate a larger immune response, which supplies better protection to older adults against influenza. We have kind of two categories of influenza vaccine. There's the trivalent inactivated influenza vaccine. These have been around a long time, since the 1940s. They're administered by injection. Again, these are inactivated influenza vaccines. So these are not capable of producing an influenza vaccine or influenza infection in people who have this vaccine administered to them, because again, they're not activated forms of the virus. But we can also give live attenuated influenza vaccine. We've been using these since 2003. These are the vaccines that are typically given intranasally. But again, because these are live viruses, they can cause a very mild form of influenza. So people who get the live attenuated are more likely to show some signs and symptoms of flu infection. And these are also not appropriate for people who are pregnant or people who have any degree of immunocompromise. So then we'll talk about pneumonias. By definition, pneumonia is a respiratory disorder that involves inflammation of lung structures, so things like the alveoli and the bronchioles. The most common cause of pneumonia are bacterial infections, but as we mentioned with influenza, they can also be caused by some viruses. And they can also happen due to non-infectious agents. So things like aspiration of gastric secretions or aspiration of food or fluids into the lungs can also cause pneumonia. There are several different ways that we classify types of pneumonia. The first way is according to the source of the infection. And this is where we group things into either community-acquired types. So these are just like they sound. These are pneumonias that people develop out in the communities. And we contrast that to hospital-acquired pneumonias. So pneumonias acquired in the hospital. So things like ventilator-associated pneumonia, which is specific to patients on ventilators. So if some sort of hospital is this location is the source, then it's a hospital-acquired pneumonia. We can also categorize pneumonias by the type of infectious agent. So we have typical pneumonias that usually result from infection from bacteria. And when someone gets a bacterial or a typical type of pneumonia, those bacteria multiply extracellularly, but in the alveoli. So if we look at the picture here, the kind of sacs or circles where we see like kind of the little purple microbes, those are the alveoli. And so this is what a typical type pneumonia would look like. We see those microorganisms multiplying and infecting within the alveoli. They're outside of the cells, but in the alveoli themselves. And so we see like kind of some of the typical signs and symptoms we see with pneumonia, which we'll talk about momentarily. Atypical pneumonias are usually caused by maybe our viral causes or something called mycoplasma infections. They involve the alveolar septum and the interstitium of the lungs. So that picture is kind of right here. And so the alveoli you see aren't really involved in this case. The infection is actually in that kind of interstitial area or in the spaces between the alveoli. So that is what we call an atypical pneumonia. That's usually associated with the non-bacterial causes. Atypical pneumonias usually produce less conspicuous symptoms and physical findings than bacterial pneumonia. So something like a mycoplasma infection is what we usually term walking pneumonia. So those patients may have like a significant cough. They may feel kind of tired, but they don't have sort of the same sort of serious and outward signs that we might see with a typical bacterial pneumonia. We can also categorize pneumonias by the immune status of the host. Whether or not the host is immunocompromised or not immunocompromised is another way that we sometimes categorize pneumonias. There are certain pneumonias that only occur in immunocompromised patients, as we discussed back in the HIV section. And so again, those would be falling into that immunocompromised host that we wouldn't see in regular well people. So we're going to talk now about those acute bacterial pneumonias. So these are our typical pneumonias, those pneumonias that multiply within the alveoli that are kind of the most common pneumonias that we see. So healthy people can be colonized and carrying the organisms that transmit these bacterial infections, but because they don't show any evidence of infection, they're just carrying and spreading that. So healthy colonized people largely spread different strains of pneumococci, and sometimes even more antibiotic resistant strains. So kind of an important thing to think about when we talk about how to like prevent pneumonia infections, just knowing that healthy people can be carrying these and spreading these without their knowledge. But these bacterial pneumonias tend to be kind of an important cause of mortality among older adults, as well as people with debilitating illness, because they, unlike healthy hosts, are quite susceptible to these bacterial infections that can lead to significant clinical manifestations and infection with pneumonia. Also, people who have maybe loss of a cough reflex or damage to the ciliated endothelium within the respiratory tracts, any other impaired immune defenses, this predisposes them to not only colonization, but infection of the lower respiratory system. Streptococcus pneumonia is the most common cause of bacterial pneumonia infection. So with pneumococcal pneumonias, they follow kind of a typical sort of four-step progression in the disease. So again, pneumococcal pneumonias from Streptococcus pneumonia is the most common cause of bacterial pneumonia. In the first stage, in that edema phase, the alveoli start to become filled with kind of protein-rich edema, protein-rich edematous fluid. Um, so that's the edema stage, and you can kind of see that sort of right up at the top. The next stage is red hepatization. In this stage, we see an increase in capillary congestion around the alveoli, and this leads to kind of this massive outpouring of leukocytes as well as red blood cells into that tissue. And so the tissue starts to actually look like liver tissue, and that's why we call it hepatization. Um, so it's kind of this sort of like red, kind of beefy looking tissue, which is not how lung tissue would normally look. But it's so highly congested because of uh, the infiltration of red blood cells that it has that appearance. Um, Another thing that happens is the lung tissue starts to become kind of firm, also more like liver tissue. The next stage is gray hepatization. Lung tissue stays kind of really firm like it did in red hepatization, but some of that kind of red blood cell infiltration is starting to ease. So we have less of that redness, but still that kind of overall firmness of the tissue. And in the resolution phase, that lung tissue kind of starts to gradually return to normal until it goes sort of all the way back to its baseline of appearance. So the clinical manifestations kind of track along with those different stages that we talked about in pneumonia. But they can also, the signs and symptoms can also vary pretty widely from person to person, depending on the person's age or health status. So these aren't always the same as far as severity and length of symptoms. So the onset of pneumonia is usually pretty sudden and is characterized by malaise, severe shaking, chills, and fever. Patients also develop kind of this pleuritic pain, meaning pain around the lungs that can become more severe when taking kind of a deep breath in and out. They also experience at the start watery sputum, and this is typical during that sort of early edematous phase of pneumonia. And then it starts to progress to more blood tinged and then rust colored to purulent drainage as the person moves through those like red hepatization and then gray hepatization changes of pneumonia. In older adults, because they don't tend to have the same fever response, we may see signs and symptoms that are a little less typical. Things like appetite changes or changes in mental status might be more common than things like fever in older adults. So treatment of pneumonia, one important treatment is prevention, especially in patients who are more immunocompromised, who may be more susceptible to developing pneumonia infections rather than just colonization. So we recommend immunization for anyone over the age of 65 or older, and people who are between the ages of 2 and 65 who have either severe chronic illnesses or who are immunocompromised. Once someone gets a bacterial pneumonia, the treatment is usually with some sort of antibiotic and also supportive care. So things like proper hydration and humidification to help thin secretions. With severe cases, we may provide things like supplemental oxygen. In very severe cases, it could be as supportive as ventilatory support. Coughing and deep breathing support is also important for these patients, nutritional support, all of the things we would typically do with anyone with an infectious illness. Okay, so we're going to move on to tuberculosis. So tuberculosis, or TB, is the world's largest cause of death from any single infectious agent. And what we're seeing right now is that TB infections worldwide, as well as in the United States, are on the rise. Um, Tuberculosis infection is caused by the Mycobacterium M tuberculosis. An interesting feature of this mycobacterium is it has this kind of waxy outer capsule that makes them very resistant to destruction. So once someone becomes infected, it is very difficult to kind of really fully kill that mycobacterium. It is also airborne transmission, and airborne transmission tends to be kind of the most contagious type of transmission for any sort of infectious agent. Um, this mycobacterium can infect practically any organ of the body, but the lungs are the most frequently involved. The thing about Another thing about tuberculosis, as I mentioned, it has that waxy outer coat. So, in the early stages, the body can mount an immune response. It can basically surround that mycobacterium and prevent its spread and can kind of cause it to go into latency initially. But the mycobacterium does persist kind of in the system. The other thing about this disease is that the destructive features of the disease, things like what we call caseating necrosis and cavitation, which are these sort of severe lung changes that we see with TB, are actually not so much from the bacteria itself, but they result from hypersensitivity immune responses um, of the host's immune system against the tubercular bacillus. So, that macrophage directed attack is what results in parenchymal or lung tissue destruction. Okay. So you can see here as someone inhales that tuberculosis bacillus, it gets into the lungs. And we're going to talk about primary versus secondary tuberculosis a little bit more. But in primary tuberculosis, as it enters the lung, it creates this cell-mediated hypersensitivity response. Cell-mediated immune response. This will also confer a certain amount of resistance to the organism. And you can also see that is what creates that positive skin test, which was one of the diagnostic tests that we use in a patient. It also creates sort of a resistance to reinfection if that were to occur. But after that cell-mediated hypersensitivity response occurs, we get this granulomatous inflammatory response within the lung tissue. And this creates something called a Ghosn complex, which is a typical thing that we can pick up on X-ray in patients with tuberculosis infection. And so usually, again, people who have this kind of primary tuberculosis infection, after this immune response, usually create these kind of healed dormant lesions within the tissue themselves, where the immune system kind of surrounds and encases that initial infection and causes that infection to go into a latency type period. So a little bit more about primary TB. It's really the form of the disease that develops in anyone who was previously unexposed and unsensitized to the disease. So in this case, this is the first time they've ever been exposed to the virus. This is the typical course on that primary infection. So they develop some immune system response. They're now going to be skin test positive, but for most people, they're able to kind of surround and send that infection into this sort of latency period. So again, people with early initial infections usually result in latent TB, and those with latent TB cannot infect others. So once that TB infection becomes surrounded by the immune system, that person is no longer infectious and they're not going to show any outward signs of TB. But for people who might have a weakened immune response, these folks can develop what we call progressive primary TB, where they don't go into that latency period, and there is initial destruction of lung tissue, and TB spread to multiple sites within the lung. People with primary progressive TB usually present with things like low-grade fever, fatigue, and weight loss. An initial dry cough that usually becomes productive and sometimes purulent and sometimes blood tinged. They also develop dyspnea and orthopnea, especially as the disease advances to late primary progressive TB. Other things that are common are night sweats, anemia, and rales on lung auscultation throughout the disease progression. Those with active infections can also infect others. So anyone showing signs and symptoms of TB need to be isolated from anyone uninfected to prevent that spread. Okay. Primary progressive TB represents either reinfection from inhaled droplet nuclei or, especially again in those who have seen it before, or it can be reactivation of a previously healed primary lesion. So those who have primary TB that goes into latency, sometimes that latent TB can reemerge and cause progressive TB later on. So the diagnostics for tuberculosis, so we have the TB skin test, but just because someone has a positive TB skin test doesn't mean they have active tuberculosis. It only means they have exposure. We also see false negatives in people who are immunocompromised, meaning their TB skin test is negative, but they are in fact infected. And this is because their immune system is not strong enough to have created enough of immune response to show up on a TB skin test. The definitive diagnosis of TB really requires positive cultures for that mycobacterium to definitively say it's tuberculosis. TB treatment can be relatively difficult and often tricky in patients. Um, the thing about TB infections is that they occur kind of more commonly in places where people are kind of packed more closely together, so institutional kind of settings. We see them a lot more and spread more readily in like prison populations or in homeless populations. And so making sure that people are receiving access to treatment as well as remaining compliant to treatment can be very difficult because of the populations of patients this tends to affect. Um, the other thing is that it often requires the use of multiple drugs for a relatively long period of time. We're talking 3 to 6 months at least of consistent multi-drug treatment to eradicate TB in a patient. Um, Two groups of patients really qualify for treatment. Either people with active TB, we don't tend to treat latent TB with antibiotics, so just really active TB, or people who have had contact with those who have active TB who are at high risk of developing an active form of the disease. So we would use prophylactic treatment for those who are immunocompromised as well and who have had active treatments before. Um, the goal here is to really eradicate infections without increasing antibiotic resistance. This is the other thing that we're seeing more and more now with TB is that it's becoming more and more resistant to our typical antibiotic treatments. And so this is why we don't want to overtreat TB. We want to make sure that there are just certain populations who really need treatment who receive it, but also that we're trying to reduce the amount of people with active TB in the population to prevent further spread. So then we'll move on to lung cancers. Some of the major causative factors of lung cancer are smoking, asbestos exposure, as well as a familial predisposition to the disease. And people can develop primary lung cancers. 95% of those lung cancers show up in like the alveolar tissues of the lungs. And then another 5% show up in bronchial, glandular, and lymphoma tissues in the lungs themselves. Secondary lung cancers are those that appear via metastasis from other sites. So some different categories of the different bronchogenic carcinomas that we see. So squamous cell lung carcinomas that those make up about 25 to 40% of the cancers that we see in patients. These are the cancers that are most closely related to smoking. So typically if someone develops a cancer related to smoking, it's most commonly a squamous cell lung carcinoma. Adenocarcinomas make up about 20 to 40% of lung cancers. These are actually the most common type that we see in North America. These are not as closely linked to smoking, and these are the type that we most commonly see in women and non-smokers if a lung cancer were to develop. Small cell carcinomas, these make up about 20 to 25% of lung cancers. They have very small, round, oval cells. These tend to be very highly malignant, and they also tend to infiltrate widely and disseminate throughout the body really early in their course. They're also rarely resectable by surgery. And often what we see is that brain metastasis is really common in small cell carcinomas, and that's usually the first evidence that even a tumor exists. So a lot of folks diagnosed with small cell carcinomas actually come in with signs and symptoms of brain metastasis before we even diagnose the carcinoma evident in the lungs. And then finally, large cell carcinomas. These are about 10 to 15% of lung cancers. These are very large polygonal cells. These also spread very early um, in the development of the disease. And because of this early spread, they really have a generally kind of poor prognosis as well. So, with manifestations of lung cancer, some of the clinical manifestations we see are those that are due to involvement of the lung and adjacent structures. They also can be the overall effects of local spread as well as metastasis. So, again, as we mentioned, that some folks with small cell lung carcinomas, the first signs and symptoms they would have are those that are associated with the spread to the brain. Things like maybe confusion or seizures or headaches might be early signs. We also have non-metastatic paraneoplastic manifestations that are relatively common with lung cancer. So these are things like endocrine signs and symptoms, or neurological signs and symptoms, or different things that we see within connective tissue. Um, those are pretty common with lung cancers. And then there's also some non-specific symptoms like anorexia and weight loss. Sometimes with lung cancer, some of the symptoms may be missed before spread even occurs because the symptoms are those already common in maybe people who smoke. So things like chronic cough or chronic shortness of breath that might indicate cancer might be things that are already present in that individual. Um, things like wheezing or other airway, you know, issues or hemoptysis. Um, so again, sometimes we miss some of those early signs and symptoms. So let's talk then about respiratory disorders in the neonate, what we call RDS. And RDS often occurs in premature infants because in premature infants, what we see is this pulmonary or lung immaturity, and also what we call a surfactant deficiency. And surfactant helps to kind of keep airways open, but surfactant doesn't develop and become fully present in the lungs until much later in fetal development. So in premature infants, they often don't have adequate levels of surfactant. And again, we combine that with immature lung structures, and that's why we see significant amounts of what we call respiratory disorder, or excuse me, respiratory distress syndrome um, in neonates. So this combined decrease in surfactant with immature lung structures lead to decreased lung compliance. So the lungs aren't able to kind of expand and contract appropriately. This leads to something called atelectasis as well, which is the kind of um, like closure or collapse of the small alveoli within the lung tissue. And these things lead to an overall development of hypoxia because we've lost a significant amount of surface area for gas exchange as the atelectasis occurs within the alveoli. These can lead to things like pulmonary vascular constriction. So the vasculature, the blood supply to the lungs themselves can start to constrict. And this leads to a further reduction in gas exchange in the lungs. This also can lead to pulmonary hypertension, so an increase in the vascular kind of resistance and an increase in pressure in the pulmonary circulation. And this leads to an overall decrease in the perfusion or blood supply to the lungs themselves. So that's one major component of the development of RDS in neonates. The other side of that is we have this increased we have increased pulmonary capillary permeability. So the capillary beds surrounding the alveoli become more permeable. This leads to movement of fluids into the alveoli themselves. Um, and this damages the hyaline membranes and kind of destroys them within the lung tissue itself. And so now we've got more fluid within the lungs and more difficulty in overall breathing in these infants. Bronchopulmonary dysplasia, or BPD, is a chronic lung disease that can also develop in premature infants who have been treated with long-term mechanical ventilation. And so maybe babies who were born early and have respiratory distress syndrome and then are put on a ventilator can then go on to later develop this kind of chronic bronchopulmonary dysplasia. Um, so other factors here, um, the presence of insulin also tends to inhibit surfactant production. So kind of this piece right here. So if we have infants who are born to mothers with insulin-dependent diabetes, they are also at increased risk for developing RDS. And another factor is that cortisol can actually accelerate the maturation of type 2 cells within the lungs and also accelerate the formation of surfactant. So when we have premature infants who are born by cesarean birth instead of vaginal birth, they are also at higher risk for the development of RDS. That stress of vaginal delivery on the infant can cause an increase in cortisol. So if we take that stress away through cesarean birth, it can reduce the amount of surfactant production. So another kind of factor related to that piece. Some prominent signs of RDS or respiratory distress syndrome are central cyanosis. Breathing also becomes difficult. We may see retractions in the infant's chest wall. We might see kind of a descending diaphragm. They also typically make these kind of grunting sounds, especially with expiration. They have low tidal volumes because of the amount of atelectasis. They usually have really high respiratory rates that can be as high as 60 to 120 breaths per minute as they're trying to maintain their normal minute ventilation. They also develop fatigue very rapidly because of this overall increased work of breathing. A little bit about respiratory disorders as well in children. Frequent infections occur in children because the immune system, especially of infants and small children, is immature at first, but then also because these children have been exposed to far fewer pathogens. So they still have to kind of develop that immune system memory to be able to fight future infections. Also, the infants and children have much smaller sized airways than adults. And so they're much easier, their airways are much more easily impaired as far as airflow and much more easily obstructed with any sort of kind of inflammation and swelling. Um, so especially with upper airway infections, things like viral croup can develop. This happens when viral infections affect the larynx, trachea, and bronchia. So you can kind of see that here. This is something called epiglottitis, but this is a dramatic, potentially fatal condition that's characterized by inflammation and edema of the supraglottic area. And so you can see as that becomes inflamed, it very easily starts to close or obstruct those much smaller airways that we see in children. And with croup, what we hear in children is stridor or these kind of barking coughs because that airway obstruction is so significant. And so if we have signs of croup, we need to watch for significant respiratory distress in these children, like nasal flaring and substernal intercostal retractions, because again, they're signs of very significant airway closure and obstruction. Epiglottitis, like you see in the picture here, is a medical emergency and requires immediate establishment of an airway, usually by endotracheal tube or tracheostomy, to be able to maintain ventilation in these patients. So just to reiterate, so you are very aware of the signs of impending respiratory and failure both in infants and children. So as we mentioned, one sign is cyanosis. Another is very high heart rates, usually greater than 150. And we can also see very rapid breathing, 60 to 120 breaths per minute. But we may also at times see the development of severe bradycardia and even depressed breathing in these children, especially if severe fatigue from work of breathing has set in. Retractions are also very common. I think we watched videos of retractions in our 2015 course, so you're aware of what that looks like. Nasal flaring is also a common sign of respiratory distress in children, and grunting, especially during expiration. And they might also experience anxiety and agitation and significant fatigue.